Welcome. Thank you so much for joining us this evening. I also want to thank our generous community of donors and our board of directors for making possible this event and everything else we do. Millions of Alzheimer's patients, caregivers, and loved ones around the world are depending on science to defeat this disease, and we at Cure Alzheimer's Fund know they deserve everything we can do to accelerate it. My name is Meg Smith. I am the Executive Vice President for Research Management at Cure Alzheimer's Fund. While many of you already know Cure Alzheimer's Fund well, before I turn things over to Dr. David Holtzman, I would like to take a couple of minutes to introduce Cure-Alz to those new to us. We will then hear from Dr. Holtzman. He and I will have a conversation about what he has shared with us and his work in Alzheimer's more generally, and we will then turn to your questions. To ask a question at any time during this event for me to pose to Dr. Holtzman during our Q&A, please type it into the Q&A feature in Zoom. Your question will only be visible to Cure-Alz staff. Cure Alzheimer's Fund is a not-for-profit with the mission to fund research to accelerate prevention, treatment, and a cure for Alzheimer's disease. We exist only to bring an end to this disease and the terrible toll it takes on patients, families, caregivers, and communities in the United States and around the world. Since our founding 16 years ago, thanks to the support of our dedicated and generous community of donors, we have provided more than $125 million in funding to top scientists in Alzheimer's and related fields. Our supporters know that 100% of their donations go to science because our board of directors covers all of our operating budget. The founders of Cure-Alz knew that a disease as complex as Alzheimer's would require extraordinary expertise to solve it. And so they established as a core principle that science and data would always drive our funding and activities. Their own expertise in venture capital and business taught them that empowering great talent yields great results. And Cure-Alz has operated on that basis ever since. Thus, the Cure-Alz Research Leadership Group, comprised of top researchers active in a wide range of scientific specialties implicated in Alzheimer's disease, determines our research priorities and makes all of our scientific decisions. Thanks to their vision, scientific findings funded by Cure-Alz have repeatedly changed the way the entire Alzheimer's field understands and attacks this disease's complexity. Cure-Alz supports research in labs around the world and fosters sharing of information and collaboration among them so that their work can have the greatest possible impact. We are grateful for our research leadership group's guidance and for the extraordinary work they and all of our funded researchers are doing to put an end to this disease. And speaking of our research leadership group, I would now like to turn our attention to Dr. David Holtzman, from whom it is truly a privilege to hear this evening. At Washington University in St. Louis, Dr. Holtzman is the Andrew B. and Gretchen P. Jones Professor and Chairman of the Department of Neurology, a Professor of Developmental Biology, Associate Director of the Knight Alzheimer's Disease Research Center, and Scientific Director of the Hope Center for Neurological Disorders. As a national leader in Alzheimer's research, he has served on the National Advisory Council of the National Institute of Aging and the National Institute of Neurological Disorders and Stroke, as the president of the American Neurological Association, and has been elected to the American Academy of Arts and Sciences. As a highly respected and truly beloved lab leader, Dr. Holtzman has trained over 60 graduate students, postdoctoral fellows, and physician scientists who, thanks to what they have learned from him, have themselves gone on to do groundbreaking work in Alzheimer's and other neurological diseases. Along with all of these roles, he also finds time to be one of Cure-Alz's most important research leaders. He was a member of our original research dream team, and now as a member of both our research leadership group and our research strategy planning committee, he is integral to our day-to-day scientific decision-making. He is also the chair of our Fleming APOE consortium and is one of our greatest resources on a wide variety of Alzheimer's-related questions. We could host a whole series of webinars with Dr. Holtzman on all of the areas in which he has been a pioneer and a paradigm shaper throughout his career. But today, we have the honor of hearing from him about the first clinically available diagnostic blood test for Alzheimer's and what it will mean for patients and for researchers. Since he is both a co-inventor of the blood test and a clinician who is using it in his practice, he is truly ideal to introduce this breakthrough to us all. Without further ado, please let me introduce Dr. David Holtzman.
Thank you so much, Meg, for that very kind introduction. And before I get started, I really want to thank Cure Alzheimer's Fund, which I think has made such a huge difference in some of the most impactful research on Alzheimer's disease over the last 16 years. So I'm going to update everyone on blood-based biomarkers for Alzheimer's disease and their promise both currently and in the future. So I think it's important when one thinks about biomarkers for Alzheimer's disease to understand the basis for what they're trying to identify. So there are many different diseases that cause cognitive impairment and dementia. Alzheimer's disease is the most common. And the underlying pathology in the brain that's linked to Alzheimer's disease is illustrated in this cartoon slide, which shows that there are two normal proteins. One is called amyloid beta, here in red, or A beta 42. And another one is called tau, which is labeled here in blue. And these proteins are made in our brain all the time, and they float around and don't really cause a problem. But unfortunately, in some people, they start to aggregate or clump together, as is shown with these red squiggles. And this represents the amyloid beta that's accumulating in amyloid plaques. The other thing I mentioned is the tau protein here normally is floating around inside nerve cells, but it also can clump up and aggregate together, forming what are called neurofibrillary tangles. And it is these structures that not only characterize the disease, but also contribute to the cause of the disease. And these are the things so far, some of the major things that people are trying to identify as markers of the disease or biomarkers of the disease. So it's important to understand that the pathological changes in the brain that account for or occur in Alzheimer's disease start many years before the clinical manifestations. So on this graph, if this black line here represents the beginning of the impairment or cognitive impairment that occurs, so when somebody first starts developing memory loss or mild cognitive impairment, MCI, if you were able to look inside the brain of that person at that point, these amyloid plaques here shown in the red line have already accumulated to great extent in the brain. And the neurofibrillary tangles, which are in the blue, represented by the blue line, they're just starting to build up in the brain when the symptoms begin. So some of the things we're trying to identify with different markers, like the blood-based markers I'll talk about, is whether or not these pathological elements are present in the brain. So it's probably important to define what is a biomarker. So it's almost any measurement that reflects an interaction between a biological system and a potential hazard, which may be chemical, physical, or biological. The measured response may be functional and physiological, biochemical at the cellular level, or a molecular interaction. So some very common examples in medicine of biomarkers include pulse, blood pressure, LDL and HDL cholesterol. These are all markers for things that might predict that someone might develop, for example, a heart attack or a stroke in the future. In the case of Alzheimer's disease, the biomarkers we'll discuss today are those that objectively mark aspects of Alzheimer's disease pathology in the brain, the amyloid plaques, the tau tangles, and ultimately what's called neurodegeneration, or the brain injury and cell death that occurs as the disease progresses. So how are Alzheimer's disease biomarkers used? Well, they've been used for a while now in research to understand the underlying causes of Alzheimer's disease. They've been actively used in clinical trials. So for example, in treatment trials, they can be used to confirm that Alzheimer's disease is the underlying cause of the cognitive impairment that you're seeing in a person, as opposed to another disease. In prevention trials, they've been used to identify cognitively normal people who already are developing Alzheimer's brain changes. And then in terms of target engagement of, let's say, a treatment, they can be used to confirm that drugs are affecting Alzheimer's disease related targets, such as amyloid buildup in the brain, as an example. In the clinic right now, in patients, currently to evaluate for Alzheimer's brain pathology, these are used in patients where the clinician suspects Alzheimer's disease as the cause of cognitive symptoms, but the clinician is not certain that's the cause. And in the future, when we have disease-modifying therapies, such as pills, antibody injections, or other interventions, a test confirming that underlying Alzheimer's pathology is present is likely to be required to start treatment. I'm sure some of the questions we'll talk about in a few moments will be, in the example, there's an antibody right now or a treatment that it could potentially be approved within the next few weeks by the FDA, a treatment called aducanumab. And if that treatment is actually approved, it will be required that in order for patients to get treated with that antibody, that it be determined that the person actually has amyloid in the brain. And that's one of the tests that we'll talk about in a moment. So what are the advantages of a blood test? Well, there's many of them. One, practically, individuals are comfortable with having their blood drawn, as opposed, for example, to having a lumbar puncture, which, while it's not actually overly painful when done properly, still most people would rather have their blood drawn than get a lumbar puncture. Blood can be drawn almost anywhere, and samples can be shipped to labs for testing. And in the longer run, the costs are likely to be lower than some of the other types of tests that are done. Some of the scientific advantages are that multiple proteins can be measured within a single blood sample. Results are a number rather than a more subjective read, and that facilitates interpretation of the results. And the studies could measure Alzheimer's biomarkers without the burden, as I mentioned earlier, of things like lumbar puncture or imaging, for example, with radioactive materials, which have some inherent risk. And then the potential impact on clinical trials in the clinic are that participants in clinical trials could be screened and recruited more rapidly in a much more cost-effective way, speeding development of effective treatments. So right now, about less than 5% of people who have dementia are even evaluated with Alzheimer's biomarkers. And if an accurate blood test is developed, this could increase to close to 100%. And more widespread use of blood-based biomarkers will likely lead to earlier and more accurate diagnosis of Alzheimer's-like dementia. So one of the things that the blood test I'm going to talk about is trying to determine is if somebody has the development of those amyloid plaques in the brain that I showed you earlier. So around 2004, the first agent was developed that could detect amyloid plaques in the brain by Bill Klunk and Chet Mathis and colleagues. And that's called Pittsburgh Compound B, or PIB. This is a diagram of a small molecule that they showed can be injected into the blood. And if it was radioactively labeled, it would get into the brain. And then an image was taken of the brain and imaged whether this radioactive substance, given in very small amounts, was bound to amyloid in the brain or not. And you can see the results on the bottom is a patient who was thought to have Alzheimer's disease. And the red and yellow colors are the binding of this small molecule that got into the brain to amyloid plaques. And then this is a control subject, somebody who's not demented, who did not have any binding of this material. So this is a really nice test to determine if you have amyloid in the brain, which is great. It's just that this requires the use of a PET scanner and radioactive materials and requires centers that have the appropriate scanners and physicians and technicians to do these kind of tests. And right now, if this kind of a test, which some tests like this are now clinically available, they're very costly. They're cost most places $5,000 to $7,000 for one amyloid imaging scan. So beginning, 15, 20 years ago, it began to be determined that if you look at the fluid that surrounds the brain, the spinal fluid, and you measured the measurement, this compound called amyloid beta 42, which I showed you earlier is the material that builds up in amyloid plaques, that if you do concomitant cerebrospinal fluid testing with amyloid imaging in people, what you see is that those who have high PIB, who have high amyloid in the brain, have a low level of cerebrospinal fluid A beta 42. So this is the material that makes up the plaques. And in the people that have no amyloid in the brain by the PET imaging scan, their levels are almost all of them have higher levels of this compound. So What's happening is that, as I mentioned earlier, this A beta 42, which floats around, gets stuck in the brain to the amyloid plaques. And so when you measure it in a person who has amyloid plaques, it's lower than people who do not have amyloid plaques. There's a little bit of overlap, but it's generally a very good test to determine if you have amyloid in the brain. So what's happened over the last few years is that people began to develop very accurate ways of measuring this amyloid beta 42 and other amyloid molecules in the blood, and have found that the measurements in the blood, when done very accurately, show very similar results to these cerebrospinal fluid tests. And that's illustrated in this slide, where several groups have reported that if you do high precision assays where you measure this amyloid beta 42, and if you normalize it to a shorter form of the same molecule, that this ratio measured in the blood by a technique called mass spectrometry is highly concordant with amyloid PET scans, especially after you consider the ApoE4 genotype. So ApoE is a genetic risk factor for Alzheimer's disease, and if you combine the results from this measurement with the knowledge of one's ApoE genotype, this test can be quite accurate at determining whether or not you have amyloid in the brain. And so this is an example from a paper published from Randy Bateman's lab at Washington University, who developed this particular mass spectrometry-based test. And you can see that in people who have amyloid in the brain as measured by a PET scan, the majority of them have a lower level of this ratio than the people who have a negative amyloid PET scan. And the accuracy of this test is very similar to what you find when you do the cerebrospinal fluid test for the same measurement. So this test was recently licensed to C2N Diagnostics, which is a company that Dr. Bateman and I co-founded along with Joel Bronstein back in 2007. And the company has modified this test so that they combine the results of the test with one's ApoE genotype. And if you combine that with age, they've come up with the first CLIA approved, so clinically available blood test. And they come up with a score that represents all of these factors together. And so this graph on the bottom shows results from over several hundred individuals that had amyloid imaging and were either positive or negative. And then the results of this amyloid probability score was calculated, again, from these measurements. And what you can see is that most of the people had either a high score up to the right of this red line or a low score to the left of this red line. And the interpretation is that if your score is above about 60 on this graph, you're very likely to have amyloid in the brain. And if your score is below this red line, you're very unlikely to have amyloid in the brain. And this is the test that has now become clinically available that physicians can order in their offices if they want to choose to do that. What's likely to occur is that there are additional blood tests will likely follow both at C2N and from other groups. So there's research studies to show that measurements of the tau protein, which is in the neurofibrillary tangles, also can be very, very helpful as an Alzheimer biomarker. And there's a measurement of another molecule called neurofilament light chain, which tends to indicate damage in the brain. And I suspect what will happen is that both at C2N and possibly other places, a number of these markers will all be measured concomitantly to most accurately predict not only whether there's amyloid in the brain, but at what stage of the disease one is at a given time. So this test has received a lot of notoriety recently, and we were actually a question on Jeopardy this week when this question in the fall of 2020, the first blood test became available for this top 10 US cause of death was a question, and diagnosis by symptoms is tricky and brain scans are costly. So obviously the answer is, what is Alzheimer's disease? And this reflected this question came out reflecting the C2N test becoming available in the fall. So in terms of promising blood biomarkers, this A beta 42 to 40 ratio becomes positive very early in the course of this disease, in that period when amyloid is building up, when people are still clinically normal, and identifies brain amyloidosis. These other blood markers, such as phosphorylated forms of the tau protein, these increase a little bit later in the disease, towards the end of the pre-symptomatic period and in the early symptomatic period. And they also increase the more amyloid is building up in the brain. And then finally, neurofilament light chain is a measurement that's not specific for Alzheimer's disease, but it's informative about ongoing neuronal damage. So I think I'm going to stop with this slide and say that I think in the future, Alzheimer blood tests are likely to use a combination of biomarkers rather than a single analyte or marker to predict Alzheimer dementia. And models that include a number of factors such as age, sex, ApoE genotype, race, etc., rather than a single cutoff value for positive, negative, are likely to even be more accurate than the biomarkers, especially when they're combined together. So Meg, I think I will stop there, and we can open this up for questions.
Great, Dave, thank you so much. That was really informative. And I would love to ask you some follow-on questions before we turn to the audience questions. But I will address one question the audience has raised a couple of times already, because they're finding this as interesting as I am. We are recording this. We will make that recording available sometime next week after we've had a chance to do the editing that's required, just the processing piece. So you will be able to watch this again if you'd like, or to send a link to others. But Dr. Holtzman, let me ask you this. You're also a clinician. How has diagnosis worked in the past? How is this going to be different for a patient coming into your clinic?
Okay, I'll give you a good example. I've seen a few patients in the last month who presented with some concerns of memory problems, where in one case I evaluated them. They definitely had subtle memory impairment, but I wasn't sure whether or not their problem might be due to a number of different factors, such as the medications they were taking, possible depression, versus really were they developing Alzheimer's disease. And so in one case, that story I just told you, I obtained the blood test, and their amyloid probability score was 0. So I think it's pretty unlikely that person, it assisted me in trying to pursue the other things that I thought might be contributing to their cognitive problem, as opposed to, for example, putting them on a cholinesterase inhibitor, a symptomatic treatment for Alzheimer's disease. That's one example. Another one I saw recently was where I wasn't sure whether their early cognitive impairment was due to Alzheimer's or possibly another neurodegenerative disorder. And in that case also, I received a very low amyloid probability score. So I'm now pursuing other testing to try to figure out what disease might be causing their problem, as opposed to Alzheimer's.
So the test is for people with early memory concerns. But what I'm hearing from you is there are other things that drive memory issues, and dementia and Alzheimer's disease are not the same thing.
That's correct. Right. Alzheimer's disease in the United States probably contributes in some way or other to about 70% of people who develop cognitive impairment after the age of 65. But there's a lot of other things that can contribute to dementia. I mean, you could have cerebrovascular disease. You could have Parkinson's-like dementia from Lewy body disease. There's frontotemporal dementia. There's a number of different causes. They're not as common, but they're still in aggregate pretty common.
So what I'm hearing from you is that the treatment, not only would the treatment plan potentially be different, but what you're doing as a diagnostician is going to be different because you've gotten this answer about amyloid.
Right, and you can imagine when, again, if a treatment, let's say there is a treatment that is approved to remove amyloid from the brain, you certainly don't want to give that treatment to someone who doesn't have amyloid in the brain. So that's an obvious one, but that's not yet clinically, a treatment like that is not yet clinically approved, but seems pretty likely in the next few years that something that does that will be approved.
And you're an extremely experienced clinician. When you have in the past had to do a purely clinical diagnosis of Alzheimer's, how confident have you been able to be that you can look at somebody and just clinically know whether it's likely Alzheimer's or not?
Yeah. So at our Alzheimer's Disease Research Center, where there's a lot of expert clinicians, and we have seen people longitudinally over several years, our accuracy is over 90%. But when you see somebody for the first time, even if they're the best expert in the world, if somebody's only mildly impaired, we're only accurate about 60 to 65% of the time.
So this can increase your accuracy rate almost, other than that group that's in the intermediate, that's it's not quite clear, this is going to increase your accuracy to a much, much higher level.
Oh, I think so, for sure. There's no question about that. It's very similar to what there's been a number of studies done recently that have been published called the IDEAS study, where people came in with mild impairment, like the people I was telling you about. And I think over 18,000 people were in this study around the country, and they got an amyloid imaging scan. And of those people that the clinicians weren't sure if their impairment was due to Alzheimer's disease or not, the amyloid scan was positive like 65% of the time. In other words, the blood test is showing something very similar to what the amyloid imaging scan would show.
But the amyloid imaging scan costs a lot more, isn't necessarily covered by Medicare, and it certainly isn't very available across the entire country. Correct. But are you giving anything up by using a blood test instead of imaging? Does it matter where the amyloid is in the brain?
There are some advantages of certainly for research purposes, for sure, when you get an amyloid imaging scan, you not only know whether amyloid is in the brain, but you know where it is. Now, by the time people are becoming cognitively impaired, there's a lot of amyloid in the brain. So the amyloid imaging scan really doesn't, it's not, the anatomic location of the amyloid at that point it's kind of everywhere. However, the blood test becomes positive even when there's only just a little bit of amyloid in the brain. In fact, it's more sensitive for determining whether amyloid is in the brain than the amyloid imaging scan. So in the Bateman study that I showed you, there's some people that had the blood test that was abnormal, but the amyloid imaging was normal. In other words, it would seem to be, maybe it was a false positive result from the blood test. But when those people were followed over several years, almost all of them became amyloid positive. So I think it's actually a more sensitive test of the earliest stages of amyloid deposition, as well as picking up people who have a lot of amyloid deposition. So I think the blood test in the longer run will be really useful in prevention for determining people right when they become positive, so that you could start doing preventative therapies very, very early.
So what is it about a patient that says to you, this is a person I want to order this test for? What's the profile, or what are the symptoms that you're looking for?
Well, so right now, this particular test is only approved for people who have they have to have some cognitive impairment. And then the physician needs to confirm that and then decide that this test would be useful in their management. That's what it's approved for currently. But in the bigger picture of things, one could envision everybody gets to a certain age, and right now, let's say, you start getting your cholesterol checked when you're 35 years old or 40 years old. Maybe one would envision, depending on your family history and other issues, you might start getting a test like this when you're 45 or 50 to start saying, well, if it's normal, I'll wait 10 more years and get it again. If it's abnormal, then depending on where the development of treatments is, you might get a treatment, you might change your lifestyle, you might, start acting upon the result. And that's what I would see in the longer run. Right now, it's only approved for people who have some cognitive impairment to help the clinician do differential diagnosis, like what's causing the problem.
In the slide where you showed us the curves for the increase in pathology versus the clinical manifestation, you showed us that amyloid is actually increasing significantly before that clinical manifestation. So what it sounds like you're saying is an amyloid blood test could let us actually identify people when there is still an opportunity to stop that amyloid from increasing to where it will lead to cognitive symptoms.
Oh, absolutely. I think that in the longer run would be the biggest use of this test, that you identify an abnormality even before there's much amyloid in the brain at all, and then you start treating and prevent it from even accumulating in the first place. Because it starts to accumulate 20 years before symptoms begin.
So one of the things that you mentioned is that this is combined with APOE status. Can you talk a little bit more about that and why it's an important part of the test?
So even when the test is done alone without anything else, it's already very accurate at determining whether there's amyloid deposition. But the test becomes even more accurate when you combine the APOE genetic result. And actually, what we're measuring in the test is not the gene, the APOE gene. We're measuring the protein product of the gene. So it basically tells us the same thing, but we're actually measuring the protein. In any case, the reason it's helpful is that APOE, or one form of APOE, APOE4, is a strong risk factor for Alzheimer's disease, and APOE2 is protective. And so people who are APOE4 start getting amyloid earlier, on average earlier than those who do not have APOE4. And so what we found is if you factor in the fact that somebody, let's say, is APOE4 positive, if they have, with the same number of that amyloid beta 42 to 40 ratio, it makes it, with any given number, it makes it more likely that the PET scan will be positive. A little bit, it's not a huge factor, but it adds on a little bit more accuracy when you factor that in.
So just to be clear, if you get this test, will you be told what your APOE status was? And
yes, it does. Yes, you are told that with the result of it. You're told the overall AD risk, Persivity AD risk score, some number. And then you're also told the absolute value of that 42 to 40 ratio, your APOE isoform, and obviously the person knows their age. So those are the three factors. Yeah.
Will you be told whether you're carrying 1 or 2 copies of APOE4?
Yes.
Okay. But it's not a genetic test for Alzheimer's. So people who are looking for actual genetic tests, that's not what this is.
It's not, right. I mean, one's APOE genetic status tells you something about risk, but it doesn't tell you whether or not you have or don't have Alzheimer's disease. I mean, there's a lot of, for example, there's some people who have 2 copies of E4, which is a big risk factor, but never develop Alzheimer's disease. And some people who have the protective factor E2, which, even though it's protective, some people get Alzheimer's disease. So it doesn't tell you that you have the disease or not. But in terms of, right, it is helpful though in this test to boost the probability whether or not you have amyloid in the brain.
Okay. So what kind of person or patient is this not useful for? For example, if somebody already has full-blown dementia, would you want to find out their amyloid status?
Well, as of today, the one scenario where I think it potentially could be helpful is if for some reason it would be helpful for the family to know that it was likely Alzheimer's are not causing the problem, if for some reason that would benefit them in some way. But in general, I would say this test probably isn't going to be used for people who already have moderate or severe dementia.
Okay, so that's really, if a family wants to understand their own familial risk better, then there might be a reason to give someone with dementia the test, but otherwise you wouldn't suggest that.
Right. I mean, sometimes in families when a loved one passes away, an autopsy is done and then you get the definitive diagnosis. But if for some reason it's running in a family and the genetic testing doesn't reveal an obvious, autosomal dominant cause, then maybe I could envision that might be useful to know. But in general, it's not going to be used for people with severe dementia.
Okay. So before we open it up to our audience's questions, I did want to just ask you a little bit more about why this is so important for clinical trials. Can you talk about what percentage of people in past trials actually likely had Alzheimer's disease, and how we were trying to identify who should even be in trials?
So I'm only give you some estimates. It may not be 100%. It'll be close to accurate, but not. So when, for example, in the trials of anti-amyloid antibodies, but many different companies have been doing, one of the and some of them are showing some potential slowing of cognitive decline for different treatments. None yet approved, but some are showing promise. In order to do those trials, most of the companies would have a person come into a clinical trial center. Then they would get cognitive testing to make sure that they were in the right stage of abnormality for that trial. Then they would go on to get amyloid imaging, and the amyloid imaging had to be positive in order to get in the trial. And so after going through all of these scenarios, let's say you were trying to enroll 100 people, you had to screen 5 times more than that just to get to the final people that were in the trial. And that's not just the time it took to do that, which is extensive, but it's also the cost. So for example, if instead of doing a trial that way, if you screen, the first thing you did with anybody before you even saw them to evaluate them for the trial was to get a blood test, for example, that would already screen out a lot of people and screen in the people that are much more likely to then get in the trial. And I don't remember there have been cost estimates that have been made, and it would probably save about, it would cut your cost if you were a company doing a trial like that by about 70%.
And so if companies can do a trial without spending nearly as much money, they're a lot more likely to do a trial.
I would think so.
So how often can the blood test be taken for a clinical trial? So right now, imaging is used to see whether there's engagement with amyloid levels in a clinical trial. So if a therapy is working or not. If you replace that with a blood test, could you do it more often, leaving costs aside? Because it certainly would be cheaper.
So one thing that needs to be determined about the blood test, we know it marks whether amyloid is present or not, but what will be really interesting in future studies is to determine if you gave, let's say, a treatment that affected amyloid in the brain, that you can see the amyloid being removed with doing a PET scan. It'll be really interesting to know, what do you see in the blood test when you do that? If it shows a change that reflects amyloid removal, then I could imagine that the trial could rely on, or the marker of showing that the amyloid is being removed could be the blood test. So that's not, to my knowledge, that's not been done. But if that showed an effect like that, that would be a really nice way to use the test, in addition to simply diagnosing presence or absence of amyloid.
Well, I got to see Dr. Bateman make a presentation on the enrollment a couple of years ago, and I think his estimate was something to like 4 to 5 times cheaper per patient on the screening side. So really an extraordinary improvement. I do want to turn to our Q&A because we have lots of people asking questions. The first question I'd like to pose to you is, for people who test positive here, what kind of support is offered? What would you say to a patient to expect from the future? What are you not able to know about their future?
So I think I'll just qualify the question a little bit to say, if there is some changes in memory and thinking that seem like they could be due to Alzheimer's and the test is positive, and that would indicate the likelihood that their impairment is due to Alzheimer's is very high. So then what would you then do for a person like that? Well, right now, I think I would counsel a person like that just the same way I've been doing for many years, which is we always offer educational things for the patient and their family from places like the Alzheimer's Association as a great system for educating people about the problem, not just the patient, but also the family. Second, we certainly institute symptomatic treatment if that was appropriate. Third, there are a number of interventions that we think there's not overwhelming clinical trial evidence, but there's a lot of circumstantial evidence that certain lifestyle factors can help people do better for longer, such as making sure their sleep is good, making sure their diet is appropriate, making sure they exercise the right amounts. So there may be common sense, but not everybody necessarily is up on all these things, and I think those can be very helpful.
So we have another question about age as part of the formula. If somebody is concerned about memory loss, but they are under 65, so potentially early onset Alzheimer's disease, is this test something that they could use?
Absolutely. I mean, while Alzheimer's disease is definitely more common, much more common after 65, we certainly at clinics like where I am see a number of people who are less than 65 who develop Alzheimer's disease. So if there is with normal aging, there is some change in the brain's ability to do certain things, but it's really doesn't affect one's function with normal aging. In other words, it's not normal to be repetitive, to repeat stories, to forget recent events. What is normal sometimes as we get older, we aren't quite as good at coming up with names, and we don't quite think as fast, but if you really are developing recent memory abnormalities that don't go along with that, then you should get evaluated, because it could mean it's Alzheimer's, but it also could mean it's something else.
So whatever your age, the test is still relevant, as long as for someone with memory concerns.
Right, we haven't tried to assess this much in people, let's say, less than 40. So I don't have as much information about that.
But that would be incredibly rare for Alzheimer's.
Yeah. Well, the only time that could be valuable perhaps is in families that might have autosomal dominant Alzheimer's disease. But
okay. So we have some questions about availability. I know you're not a regulatory person, so and the situation is changing. But if somebody wanted to ask their doctor for this test, would they go to their primary care provider? Would they go to a neurologist? Is it normally, or is it covered by insurance at this point?
Yeah. So the test just became approved, a CLIA approved lab test. So it's not, the company C2N Diagnostics is also, the test has received an FDA breakthrough device approval, but it's not yet approved by the FDA. The company's trying to get that done now, but it is available, and it has to be ordered by a physician that's capable of understanding that somebody might be developing a cognitive abnormality. So the company's working with sites around the country right now to make the test available. There are a number of sites where you can get the test, but I guess I would refer people to the website for the company, and they can find out from that where might be the closest place to where they live that they could potentially get the test now. But it does need to go through a physician.
Okay. And there is a list on that website of the states that have separate requirements for approval, and so where it's not yet available, but it's a small number of states.
Right, it will be probably approved pretty much in all 50 states soon. Not quite yet, but soon.
Okay. And on this FDA piece, getting the breakthrough designation was phenomenal. That's a separate question, though, of course, than the FDA's approval. But what is the connection among the breakthrough status, FDA approval, and Medicare coverage?
So the FDA approval has nothing to do with insurance coverage. For a CLIA-approved laboratory diagnostic test, any company that has a test like that, in order to have insurance pay for it, it has to go through CMS to get approval. So that's a different process and is not necessarily linked at all to FDA approval. And so the company is trying to pursue that currently. So the company is hopeful that will happen, so that right now that people have to pay for the test themselves, and there is some based on income level, the company has various discounts to have it cost less with people with lower income. But the goal would be to get it to be a CMS approved test.
And with the breakthrough designation, there's pending legislation that would give automatic Medicare coverage once approved by the FDA.
Correct.
But the legislation is pending. It hasn't been enacted fully yet.
Correct.
So that's great because it's getting very close to being fully accessible, both in terms of coverage and geographic locations.
No, that's really good news.
So we have a question about, would you want to know this if in the absence of a cure or a drug that would change the progression of the disease, would you want to know this? And I think this is a great question because a few years ago, I remember you were asked by a journalist, would you want to know what your APOE status was? And I think at the time you said, I'm not sure I would. Is this different?
This is different than knowing one's APOE genotype, because it really does tell you whether the likelihood that you really have Alzheimer brain changes at that time. Whereas the APOE test, it just tells you, a relative risk. So I think everybody might answer this differently depending on how they feel about certain things. I think certainly if there's a treatment, then you'd want to, I think it's certainly valuable to get the result of a test like this so that you could know whether you could get the treatment. But in the absence of a treatment, I'm not sure actually. In the case, if I was symptomatic, I think I would want to know, because then I would know whether I have a likelihood of having Alzheimer's disease or not is useful. I think clinically as a clinician, but also if I was a patient with that, I would want to know why am I having this problem, right? It helps define that much better. Like if you had a certain kind of, let's say you had a lump in your body somewhere, you might want, right now you'd say, well, what's your diagnosis? I have a lump. Well, I'd want to know if if the lump was some kind of a cancer, because it would be treated in a certain way and I might behave differently, or look for something else as a cause depending on what the diagnosis was. Same case here. I think it is important to know an accurate diagnosis when there is a clinical problem.
Because right now, this is only approved for people who do have clinical symptoms, early clinical symptoms, correct, but they have memory concerns.
Correct.
Okay. So this is, I guess, a related question then. We have a number of people saying, I've got a family history of dementia. Should I go ahead and get this test as soon as I'm 55? Right now, it wouldn't be approved for those people, but in the future, as a clinician, would you say to those people, you might want to know ahead because it'll give you a lot of information about where you may be headed?
I think right now it's very valuable for research studies to get, this is the kind of study we're doing here at Washington University and other places where we're measuring, in many people age 40 and older, we're starting to make these measurements for research purposes to better understand the meaning of the result and what happens longitudinally. I think as there's treatments that are developed over the coming years where you would want to start treating people with something as a prevention for developing dementia, I think that's when it would become very valuable to start getting tests at a certain age, whether it's 45, 50, I'm not sure when one would start yet, but that's when it would become very valuable.
So we have a question about the intermediate group, the group that was in between those two red lines you showed us. What would you do with somebody who had that kind of reading?
So right now, if I ordered that test and that was a result I obtained, and I still really wanted to know for the benefit of the patient what was going on, I'd probably go ahead and get a spinal tap, a lumbar puncture, because using the same types of measurements in the CSF are just a little bit more accurate than the blood test right now. So I'd probably get that. And also at the same time, I could determine if there was anything else that I should be worried about, like, is there any kind of infection? Is there any other thing to worry about?
So there's still something to do, even if that answer isn't clear on the amyloid positivity from the blood test. You still have options.
Yeah, I mean, and at least right now, CSF testing is covered by insurance.
Okay.
So,
So we have a question about who can read the blood test. And this gets back to the question you addressed earlier about who could order it. But are doctors going to have to be specially trained to read this? How
no,
easy will it be for them to adopt it?
yeah, so it's very straightforward. The company gives the amyloid probability score, APS, and it whatever the score is, it falls in those three categories. It says, you're likely to have amyloid in the brain, not likely, and then this small group of middle category. So, and that's all provided with an interpretation to the physician who orders the test. So they can basically tell the patient based on that result, if they have cognitive impairment and it's high and the amyloid probability score is high likelihood, then you could say that a likely contributor to their cognitive impairment is Alzheimer's disease. And if it's negative, you'd say it's pretty likely that it's probably something else that's causing the problem.
So that sounds a lot less complicated than trying to read a PET scan.
Yes. Now, for PET scans, those are read by the radiologist, and the interpretation is done, but not by the physician ordering the test.
But you've
yes,
got to have an expert reader.
Right. You need to be an expert reader. Correct.
So can the blood test differentiate likely Alzheimer's from frontotemporal lobe dementia or Parkinson's or Lewy body? Is this really specific to Alzheimer's disease?
Mostly. So in most different diseases that cause frontotemporal dementia, there is not amyloid in the brain. So that should be a good test to say it's not Alzheimer's disease, or it is. But in the case of Lewy body dementia, that is, most people who have Lewy body dementia do have amyloid in their brain, as well as synuclein, the other protein that's linked to Parkinson's. They have both. So if somebody had symptoms of Lewy body dementia and you got the test, and this hasn't been studied extensively with this test yet, but I would predict that the test would be positive in most, not all, but many cases.
So how would you pursue a course of treatment with a patient like that? I mean, how would you clinically see them differently?
I don't know if I, right now, from a clinical perspective, would see them so much differently. I think it might be useful, though, still in research studies in Lewy body dementia, because, for example, it might be that ultimately there will be trials not of things that just to get rid of the synuclein, but also things to get rid of amyloid. So, I mean, that hasn't been done yet, to my knowledge, in clinical trials, but it's something that could potentially be done in the future.
So we have a question about amyloid accumulation. Does it ever reverse?
Not that I've ever seen in humans. So I know there's a number of research participants that have been followed at our center here longitudinally now over 10 years. And once the amyloid is positive, if you look at the curves, it's positive, and then it just keeps increasing. Now, once it gets to a certain threshold, it kind of slows down and stops, but then that's when the brain's already filled with material. But I've not seen good examples where it regresses unless you do a treatment to make it regress.
And are some of those anti-amyloid treatments that are in clinical trials that you talked about, are they effectively reversing the amyloid after?
Yeah, there's at least 4 of them that clearly can remove the amyloid from the brain to differing degrees, depending on the dose and how long you give them and the particular, yes, but there's definitely good examples where it can be, in some cases, completely removed.
And what if you have amyloid in your brain? Does it automatically mean you're going to get Alzheimer's? Does everybody who's amyloid positive get Alzheimer's disease?
So that's a good question. It's been asked actually for a long time. And the only way to answer that is to follow people from the beginning of the process over many, many years, because we know that from the initial accumulation, it takes about 20 years just to get to the point where other changes like the tau changes start occurring. Of the people that we have followed here, hundreds and hundreds of people, it does look like most, if not all, will develop cognitive impairment if they're followed the appropriate periods of time. But are there some that never do? I don't know the answer to that. And part of it is they may not, because they might die from something else before they get to that point, but it does look like most people do.
Okay. So we had a question about sorry to back us up a little bit, but we had a follow-on question to something you said earlier about clinical trials. Does the FDA allow clinical trials to use the blood test for their biomarker assessment, or is it still necessary for clinical trials to use imaging for the FDA to consider their results?
That no company, to my knowledge, yet has used, for example, the blood test as the basis for their identification of patients for the clinical trial yet. So I think it certainly could be used right now for sure for screening, for sure. But that I'm not aware that companies, because the blood tests are very new. They've only, I mean, this one only became clinically available 6 months ago or so. So now one of the tests that was, I think it's likely in the next period of next few years that they will start to be used in clinical trials, but not yet.
Well, I realize that we are over time, but I would like to ask you one more question, if I may. And that is this. We have a watcher who said, you expressed optimism about amyloid clearing drugs. With all the trials that have failed, what is the basis for your optimism?
Well, for one, I'm pretty convinced if you removed amyloid before people were cognitively impaired, if you really removed it effectively, I think that would have an effect for sure, in my opinion. But of the current trials that are being done, some of them completed phase 3, other ones just entering phase 3. Several of them show data that suggests that they are getting slowing of cognitive decline in people treated with higher doses of the antibodies. Aducanumab is one, and I'm not going to get into the details of that particular set of trials, but Eli Lilly's data that was just published in New England Journal suggests in a much smaller phase 2 trial that they are getting slowing of cognitive decline when they remove amyloid with the antibody that they're using. Similar data a few years ago was published from Asahi about their antibody. So I think that it does look consistent that when amyloid is truly removed in people that have some cognitive impairment, not severe, just mild, that there is an effect going on that makes me think over the next years, one or more of these types of treatments will get approved.
Well, Dr. Holtzman, thank you so much. I have to say that one of my sources of optimism is that we now actually have the opportunity to get early and accurate diagnosis easily and accessibly for patients across the United States. And that is very much thanks to your work. You've been very generous with your time tonight. I'm very grateful for that as well. I encourage our watchers who would like more of you, I know I would have appreciated more time too, to visit our website, curealz.org, where we have a lot more of Dr. Holtzman's research summarized because we've worked with you for a long time. And there will be also a recording of this available in the next week or so. So with that, thank you again, and I hope you have a wonderful evening.
Thanks so much.